We were expecting about 20, but obviously got caught up with coffee. But I think we need to press on with time. So firstly, thank you all very much for coming. My name's Paul Jones. I work for the GMC. I'm a GMC Employer Liaison Advisor, and I cover the southwest of England. And I'm joined in the room here by my colleague Ian, who works in our Scotland office. And we're lucky enough to be joined by quite a lot of people online as well. And my colleague Katie Larn, who's an Employer Liaison Advisor in Wales, is facilitating that along with Marion McCann from our Northern Ireland office. So welcome to everyone online as well. Before I get started, just a few housekeeping things. I better check my list on this so I get it right. The session will be recorded and will be available to you after the event. I'm going to talk for 10 minutes or so, and then we're going to throw it out to a bit of a group discussion. You can access all the Q&A that's online via the app that you've downloaded, and any slides and materials will be available on the conference hub afterwards as well. So why have a workshop on providing care in a rural and remote setting? Well, basically, context is everything, and the GMC recognises that in order to be an effective regulator, we need to understand what it is we're regulating and the environment that doctors are working in. And we know through experiences like people like myself have working in the southwest and colleagues all over the country that doctors working in rural and remote geographies face a number of challenges that their colleagues working in large urban areas may not. And we just wanted to explore that today in this workshop. We wanted to share with you some of our experiences on the ground, some of the things that we see, how we're trying to tackle some of those things through our work, but also really importantly to hear your experiences, to see if we're in the right place and to hear your ideas and thoughts about how we, the GMC, may be able to do things differently moving forward. So things that we know, they're the same. Patients are the same in many ways. You still get the same mixture of age, demographics, race, the same different portfolios. We know that illness and mobility can be the same. People still get cancer, heart disease, diabetes, whether they live in central London or whether they live in the Highlands of Scotland. You still have to face those same things. People's expectations of their healthcare, regardless of where they live, are pretty similar as well. People still pay taxes. People who are accessing the NHS still have the same right and expectation to be able to be treated with care and compassion and get access to those services. And you're a doctor wherever you are. Your professional accountability is the same. Good medical practice applies, and duties of a doctor apply, and all our other bits of guidance and standards apply regardless of where you work. But we do recognise that some of those environments are different. So looking at geography, these are pretty obvious statements to make, but we know that people working in these settings work in quite large geographies. There can be GPs can be part of practices that are spread over significant areas. Centralisation of services. For example, in the geography that I cover, emergency vascular surgery is based in Taunton. I had an example a few years ago where an ambulance crew took a patient that really should have gone to Taunton to Barnstaple in North Devon. The doctors in Barnstaple were presented with a situation where really that patient shouldn't be there, but it was too critical and they needed to operate. Now the patient did experience some adverse conditions. Is that the fault of the doctor? We don't know. And that's the important thing is that we at the GMC, with our people on the ground, are really trying to understand the context that those people are working in so that we can apply that when we're considering these issues. This is one of my favourite images of the last few months. The far right there, this is an 80-year-old lady living in St Agnes in Cornwall. which is in my patch. St Agnes, beautiful little village, very close to the Royal Cornwall Hospital, an absolute mecca for second homeowners. And she got so fed up of seeing young people having to leave the area that she went and decided to spray some graffiti. But the reality is actually really serious, because the medical director at the Royal Cornwall Hospital says to me, recruiting consultants is really, really difficult. And he described a situation where a consultant had applied for a job, really superb candidate, came down with his wife and his family and turned the job down because they realised that they could not afford to live in Cornwall and have a standard of living that they had elsewhere. Now, if it's difficult to get a consultant into a job, when you start trying to recruit nurses, healthcare assistants, and all the other vital people that are there for a system, there's no wonder that Cornwall, for example, is one of the most pressurised health systems in the country at the moment, because they're struggling so much to get the right people in those areas. And also, a lot of these places in Wales, Scotland, Northern Ireland, they experience seasonal variations. So the picture of the beach there is Weston-super-Mare. 365 days of the year, that health system is challenged enough with an elderly population. There are more people on drug rehabilitation programs in that area than anywhere else in the southwest of England. And then you then throw in tourist things. So the doctors are facing significant challenges all the time. The workforce challenge, we know about recruitment is a significant challenge. International medical graduate recruitment means that a lot of IMGs are coming into the country working. If they're then placed in rural and remote locations, they're more spread out. Are we making sure that their induction, etc., is a big issue? So this is a big issue being mentioned. Competition for workforce. There's a real significant challenge the further out you go from the metropolitan areas in actually being able to recruit full-time staff into those systems. And then the knock-on effect of that medical directors talk to us all the time is because they can't recruit full-time, they're reliant on locum contracts, and they're paying through the roof for those locum contracts. That's nothing against those individuals who want to work as locums. It's not the GMC casting judgment there. It's just a reality of that situation. Vulnerability. We hear a lot, particularly young trainee doctors working in more community-based systems, not getting the MDT time, not having face-to-face handover. As a doctor working in some of those environments, you're juggling so many different hats that it can be a real significant challenge there. These are all things that people share with us on a regular basis. And I think one of the next areas which is a significant concern for a lot of people is education and training. I've made a slight mess with my slides here, so that should have come first, so I do apologise. Ignore the bars on the left-hand side. My PowerPoint skills weren't up to removing those. But the map is a heat map, and it shows the distance that doctors travel from their place of where they did their primary medical qualification. And you can see there then the significant patches across the UK where we can still see the green. And it's a well-known fact that doctors don't travel too far from beyond where they qualify, and if they do, it's a lot later in their career. So one of the things that we at the GMC are working with our partners about is how we open up that education and training, how we make it more accessible for people. I was struck by, I was in your Physicians Associates talk there, I grew up in North Wales, and, well, there we are. And, it's only now, I'm 44 now, and they're finally opening up medical education at Bangor University, for example. But, you look at the geography of that place. But then what we've also got to worry about as regulators is when those individuals do go and work in those environments, what induction are they getting? What support are they getting? And are we taking into context those environments if they do come across my patch and we have to start talking about fitness to practice concerns? And the other, I wanted to share a quote that has been shared with us from a from a colleague who's been working with us on the rural and remote credential. And I think this, to me, sums up some of the challenges that doctors working in that environment experience. You know, if you're in central London and you come across a child or adolescent who's significantly ill or experiencing cardiac arrest, there is usually some options available to you pretty quickly to be able to get them to a specialist. If you're working in the Shetland Isles and you're presented with that, you've got to be confident that you've got the skill set to be able to at least cope with the initial management of that patient. I just found that a really profound and interesting viewpoint from a doctor, and it's certainly something that I need to take into account in my role as an ELA working in the Southwest. So I've very briefly shared the sorts of experiences and observations that have been shared with us through our ROs, through other doctors that we work with. Just some of the things that we are doing as an organisation. So since 2003, we've been trying to get ahead of the agenda with this. So in 2003, we opened offices in Scotland, Wales and Northern Ireland. The roles of those offices was to understand the environments that doctors worked in, to promote the work of the GMC and the devolved administrations, and to drive improvement and change within the GMC. From about 2010 onwards, I've been privileged to be involved with what was then called the Employer Liaison Service, where we decided to basically go out there and start forming a relationship with medical leaders. And I was involved in the piloting of that, and I've been the ELA for the Southwest since 2012. And essentially, I spend my life talking to responsible officers, medical directors, and employers of doctors about concerns that they may have about doctors. And what we're trying to do there is get in there early and try and avoid unnecessary referrals into the GMC and try and support medical leaders to manage those fitness to practice issues locally. And around the same time as myself and my colleagues went in the field doing that, we also introduced the Regional Liaison Service, which essentially tries to replicate some, not all, of the functions of the national offices on the ground in the regions of England. So regional liaison advisors are on the ground, in and out of hospitals, delivering workshops, explaining GMC guidance, doing workshops on professionalism. All of this is about understanding the environment that we're working in, understanding where doctors are working so that we have the context when we fulfill our regulatory functions. And in recent years, we've taken a strategic decision to merge all of that into our outreach service so that we now have a more coordinated approach to that. One of the other things we're doing as well, and I'm conscious of time and I'm not going to take up too much more, is I've disgracefully plagiarised some slides from Education for Scotland there, but we do have permission for that. So just in case my conference organisers at the back get nervous. So we're supporting the rural and remote credential that is being developed. And this is about essentially dealing with a lot of the things that I've talked about making sure that doctors who are working in these environments have the confidence and the skill sets to be able to deal with the situations that they approach. It's going to be a four-country approach. We're currently working with the respective governments to agree all of that. In terms of a timetable for implementation, we're hoping to take on early adopters from probably the end of this year. And I think that'll be a really positive step in driving some of this work forward. So I think that's far more than enough from me talking about our experiences. What I wanted to do for the next 10 minutes or so was open that up into a bit of a group discussion. So I'm going to leave my colleagues who are online, Katie and Marion, to facilitate their discussions online. And given that we're such a small number, I think we can probably just have a little bit of a discussion here within the room for the next 10 minutes, and then we'll bring colleagues back in online and see what observations and things that people have there. So thank you for listening. I just wonder, to begin with, where does that sit with all of you in the room here? Does most of what I've talked about sound familiar, or are we going up the wrong tree here? Any things that people would like to add? How about my colleague from North Wales here? Yeah, I could just see you edging forward.
Yeah, no, it does absolutely ring true. I don't know if I'm the right person to be in this room though, because I'm already very much signed up to the fact, because I am a rural GP. I work in a small town called Montgomery, just over the Welsh border, and I work in a small town called Muchwenlock, just over the border in Shropshire, and they're both very Muchwenlock not so much because you're 20 minutes from Shrewsbury, but in Montgomery you are extremely far from everywhere else. And you know, for instance, on an on-call day, you have to be open from 8 a.m. till 6 p.m. because we are the provision of minor injury services. There are no sort of minor injury units nearby. So, I mean, I'm absolutely, convinced that we do need to be empowered to have more support in delivering. Because it is very different being a GP in the City of London to being a GP out where I am.
I just love the concept of Wales being isolated.
Yeah.
Sorry. I'm the MOD responsible officer and super person, and so I look after MOD civilian doctors and various other things, but I have civilian doctors.
bring in the online group for the last 5 minutes, hear some of the questions or observations that colleagues may have online, but also if anyone's got any further points, we can make that in here. Are you, Ian, have we got anything coming in, or have we got radio silence?
So I'm still waiting for colleagues to come back with stuff.
Let's carry on talking then.
Maybe,
Let's just wing it. Every workshop I've been to today looks so professional and slick, and here we go, just... Yes, please.
I'm Alison Moores. I'm a policy manager at the Academy of Medical Royal Colleges, and I had a couple of points. I suppose one of the challenges that we haven't considered, but
That means we're back online.
Oh, no.
You're
No
now
extra
worldwide.
So, in case they didn't hear me introduce myself, I'm Alison Moulds. I'm a policy manager at the Academy of Medical Royal Colleges. And I was going to say that perhaps one of the challenges that we haven't touched on is about how patient demographics will change in the future and how that's reflected geographically. We know that we've got an aging population, and we know that older people tend to live in or move to remote and rural areas. So how long-term workforce planning is going to reflect, or whether it can keep pace with changing demographics, I think is a big question.
Yeah.
And then the other thing I was going to say about, does this sound familiar? My background is in the history of medicine, and I would say that this does sound very familiar, and actually some of the thematic debates are also things that would have been recognisable to the 19th century medical profession. That's what my PhD was in. And they were also talking about things like the undersupply of doctors in remote and rural areas, how spread out the patient population was, sense of professional isolation, how you get into networks. Obviously then they were getting excited about different things like the arrival of motor cars and telephones and how that might transform services. But I do think there's something to be said that not only is this familiar, but it has been going on for centuries, but in different ways.
Same question, just different slight variances. Yeah, no, that's really useful. Thanks for that. It's, in a way, I suppose it's comforting in that we're asking ourselves the questions that people in previous years would have done the same. How are we doing there, Ian? Are we?
Yes, so apologies to the online group as well that we didn't have much time. I think we're just waiting for colleagues Katie and Marion to feed in some of the feedback from that conversation. So
Okay, right. So I suppose one of the things that I wanted to perhaps get out of this is, so we've had some really interesting observations, but is there anything totally obvious that we, the GMC, or people like myself who are on the ground working for the GMC, are not doing or should be doing differently, or that you would like to hear us starting to talk about? I'm not going to promise to be able to do it, but it'll be interesting, to hear that, and so that we can feed that back in.
I suppose making it more of a... Sorry. I suppose what I was going to say was making sort of remote and rural, it's obviously it's not a specialty, but I think it is more than you go and train as a GP or train as a hospital doctor and then choose to go and be and work or live in a rural area. I think there has to be a mentality, and as you said, the foresight to start to gather skills maybe possibly earlier in your career, so that you are more of a finished product and a confident person to be the only doctor for tens or hundreds of miles earlier on. Yeah. So even from an undergraduate level, putting it into the consciousness of students to think, this is a viable option. This is not something that I will end up doing. This is something that I might want to try and equip myself to be from an earlier stage in your career.
Okay, thank you. Do you want to look at the laptop and I'll take the... This is all just about getting Ian's steps in for the day. This is...
Yeah, I was just wondering if you should adjust what the GMC expects based on the distance from the nearest tertiary referral centre or support networks, because it isn't realistic to compare with what's happening, say, in central London. And do you adjust for that, and how do you do that in an objective way?
Certainly, I'll come to you now. Certainly, I think we do, and we certainly try to. I can't promise that in every single case we get it right, but certainly if we were looking at a fitness to practice question around a doctor in a sort of scenario that you've described, Everything is looked at on a case-by-case basis. The discussion that I would be having as an ELA with my RO is, right, what's the context? What situation was the doctor working in? What options were available to them? Did they look to seek help? Or if there has been an adverse impact, what's their reaction to that? What's their levels of insight? So we would certainly, even at that very early stage, be having that discussion. And then if it did need to come into the GMC and it was investigated, because obviously, as Carrie said this morning, we can't control everything that comes into us. I mean, as an ELA, I can stop a lot of unnecessary referrals, but I can't do anything about members of the public complaining to the GMC. And that's when we do try and look at it. And we're doing lots of innovative things around that as well, because the Medical Act doesn't really give us much wriggle room. And, what we're trying to do at the moment is things like provisional inquiries. So if we see a very obvious clinical case that's been complained about by a member of the public and that there has been an adverse outcome, our instinct tells us that this must have been looked at locally. And what we will do is we will go to the doctor and we will go to the responsible officer and say, we've had this complaint. Can you tell us anything about it? What's the information? And we are cutting out hundreds of unnecessary investigations every year doing that. It's not perfect, and sometimes doctors end up going through our procedures who, hand on heart, probably I would say shouldn't be. And we know how difficult that is for those individuals who end up in that situation. But I think the answer to, with the very best of intentions, yes, we do. I think you were going to come in, sorry, weren't you?
So clearly you do take into account the situation that somebody is working in, and yes, I agree being in remote area is different from being in central London, but I think it's really important that the duties of a doctor are the same and that patient care needs to be optimised. People do have different expectations in different areas, but I think it's reasonable that if somebody is having an elective surgical procedure in a remote unit, they should know that that's a safe procedure for them to have there. And similarly, the surgeon has a responsibility to know that for some procedures there is a relationship between outcome and volume, and therefore they shouldn't be doing a Whipple's procedure in Kirkwall. That would be ludicrous, because it's not an emergency, and just because they fancied it. And now we're all smiling and laughing. That kind of thing did happen within living memory, that people did daft stuff in remote and small hospitals because they had read it in a book or they'd seen somebody do it once. So we need to be clear. I think it's good to be in an understanding organisation for the GMC, but I think equally there's a responsibility. So I think that credentialing part, I think a big part of that for me would be about the responsibility. It's not just about the extra training, but there's responsibility to understand the environment you work in and what's appropriate for you to continue to do. Yeah. And certainly the surgical colleges would not support people doing surgery in order to maintain their skills for an emergency, something that they shouldn't be doing.
Okay, I've got one question. Okay, no, thank you. I think that's really useful. And I think medicine is so much more dangerous these days than perhaps in the past. Now, the question I ask myself, and I know a lot of colleagues ask themselves, is has there been a blatant disregard for patient safety? And I think if you've got a remote doctor thinking that they can do something that should only be done in a specialised centre, then I think that is something that we would want to, and I think that's something that most doctors would want us to be questioning. I've got a question at the back, and then we'll go to online, and then I've had another talk in the ear. Well, it was actually this time it was a piece of paper with 5 minutes, so we're getting...
It was more of a comment, which is in fact a follow-up comment from what you were saying. And I think we were thinking this morning about wiser choices and the questions that patients need to ask. And I was really struck by the N of Bran, what happens if I do nothing? And I guess perhaps part and parcel of the support for credentialing might well be, this, coming back to again what you said about risk assessments, it's how do we actually enable clinicians to do a proper risk assessment and to feel confident in the risk assessment that they do. I am totally unqualified to really be in this session in that I have never been a remote or rural doctor, but I have been a doctor on an ocean-going racing yacht in the middle of the Atlantic Ocean, and that did feel quite remote because I could not get medical help at all.
Yeah, no, thanks for that. Ian, have we got a couple of comments online, have we, for our last couple of minutes?
Yes, so I'm just going to probably probably just read out some of the comments that we've
Thanks.
had online. There's a couple of questions as well. I'm not sure we've got time to look at those, so let me try my
No,
best.
I've had the wave from the back. We're okay for a minute. I think
Okay, that's good.
we'll
that's
keep
good
Charlie
then.
waiting. It's all right.
Right, so the first one, we had a comment from Chris Williams, actually, the RCGP co-chair in Scotland, saying that R&R is for doctors in hospital, not necessarily always relevant to primary care, so important this element's highlighted to manage expectations.
Thank you.
Apologies, Chris, if I've misrepresented that point in any way, as I'm just dealing with what I see in front of me, though. We've got a question about whether there's an option for more than one type of rural credential. So, Paul, I don't know if you want to quickly touch on that, or you want to...
Well,
Not
the education side of stuff is not my area of expertise.
Right.
But I think, as the GMC develops credentialing, this is the whole point of developing credentialing is to fit certain circumstances. So I'm going to say yes, and if I'm wrong, then I can get into trouble. But I think, as my instinct is, I think yes, there will be.
I think at the moment they're focusing on that that model that they're going through, and then in time, as more need is identified, then that will be something that can be considered by the colleges, by the GMC and others. Comments around the challenges of accommodation and transport being ones that need to be considered. We have a comment or a question from Imad Kourashi. Sorry if I mispronounced your name, though. But can we volunteer to be an early adopter from the Isle of Wight?
I think we'll join him up with Rose in education. We'll pass the buck on that one and get him connected to the experts.
One of the ROs in Scotland has raised the challenges of workforce in remote areas and highlighted large numbers of locum doctors employed. And then I think Lawrence in Northern Ireland perhaps has been keen to raise the importance of common language to promote remote consultations. Another comment around ensuring buy-in from patients, which I think we covered in the room here as well, which is important. And one of our patient representatives was appreciative of opportunities to contribute and get involved online. They talked about joining consent, task and finish groups from the west of the country as well, so that's good as well. And I think that's the bulk of the comments that we've had in from the online audience. Yes, unless I've missed anyone, so apologies if I have.
Thanks very much, Ian. I think we're pretty much at the end now. I'll give it one more opportunity if there's anything that anyone else would like to add at this stage. If not, thank you ever so much for joining. For those of us who work in outreach, this is a really important subject, and it's something that we want to develop and learn over the coming years. So these are very much baby steps, what we've done here today. So for taking the time to come, thank you ever so much. And for those colleagues online as well for joining, we really do appreciate it. I hope you enjoy the rest of the conference, and it's just nice to be back in a room together, isn't it, really? So thank you.